Good afternoon, everybody, and welcome to disc herniation. What does it mean and how do I manage it? My name is Joe Capogrosso, and I'm a physical therapist here at HSS Westchester. On today's webinar, we're going to talk about symptoms, diagnosis, and management of herniated discs. Our guests today are Dr. Sravisht Iyer, Dr. Dena Barsoum. Dr. Iyer is an orthopedic surgeon here at the hospital. He specializes in spine care, and Dr. Dena Barsoum is a physiatrist at HSS Westchester. I want to thank you both for joining me today, and I look forward to speaking with you and getting some good information.
Our pleasure.
Yeah, absolutely.
So to start, I want to ask Dr. Iyer, first off, what is a herniated disc and what causes it?
Yeah, so I want to thank everyone for joining. Hopefully this is going to be helpful for you guys. So a herniated disc, is one of the most common problems that occur in the lumbar spine. The cause of a herniated disc is multifactorial, but before we get into that, probably a good idea just to kind of look briefly at the spine, where the disc is, and then we'll kind of talk about what a disc herniation is. So if we look at the spine, the spine basically is a series of bones separated by discs. So the way it works is you have two vertebrae, which are the bones in your spine, separated by a disc. Now, the disc helps to support the load. So when you're standing, when you're sitting, the load gets transmitted across the bones of your spine through the disc all the way down to your tailbone and down into your pelvis and legs when you're standing. So a normal disc looks something like this on an MRI. If you look on a side view of the spine, which you see here, the disc has a little bit of fluid inside it. That's this white stuff over here, along with a tough kind of fibrous shell, which shows up as these darker bands on the side over here. It has a nice tall height. When a disc is normal, the MRI looks like this. Now, this view is a cross-sectional view of your back. So imagine if you took a slice across your torso, so almost like a slice across your torso like this, and look down, this is the picture you would see. And the disc, when it's nice and healthy like this, shows up as a nice kind of circle over here, which is what you're seeing in the front, with the spinal canal in the back that has all these little gray dots, which are your individual nerve roots kind of running down to your legs. Now, when you have a disc herniation, it looks a little bit more like this, and you can see what's happened. The disc, instead of being a circle kind of over here, has started bulging back into the spinal canal a little bit and has narrowed the space for those nerve roots. So it can happen on either side of the body, on the right side or the left side. And just to kind of show you a comparison, this is an example of a patient where you can see the level here, L5-S1, has a disc herniation compressing the nerves, compared to a normal level over here where you can see a nice circular disc without any nerve compression. Now, the causes of a disc herniation are multifactorial. There's probably a strong genetic component to how it happens, with some people being more likely to have it than others. Other factors, obviously age. So as we get older, the fluid in the disc starts to disappear. So the disc actually becomes dehydrated, and the tough kind of fibrous bands that we talk about, they start to degenerate, and eventually they can bulge backwards. So age is one thing. Certain types of physical activity, so people that don't do enough physical activity, that's one risk factor. Jobs that involve prolonged sitting, prolonged driving has been thought to be another risk factor for having disc herniations. High body weight has been thought to be one risk factor for herniations, but all of those are not particularly strong. I think the biggest thing is most likely genetics is probably the most common kind of predisposing factor to having these injuries.
We looked at the lumbar spine seemingly there, Dr. Iyer. Dr. Barsoum, can a herniated disc happen in other parts of your spine?
Yes, definitely. So if we take another look at the spine anatomy, you'll see that a cervical spine, or your neck, is made up of 7 bones. The thoracic spine, or the middle part of our body, is 12 bones. The lumbar spine is 5 bones. And then our sacrum and coccyx below, the sacrum is 5 bones, the coccyx is 5 bones, but those are bones that are fused together. But throughout the cervical, thoracic, and lumbar spine, we have discs at every level. And so a disc herniation certainly can happen at any level. When a disc herniation happens in the cervical spine or the neck, it would cause neck pain, and it can cause a impingement or pressure on the nerves of the cervical spine, which would then cause referred pain typically down the arms. In the thoracic spine, disc herniations can still occur, although they're much less frequent and much less likely to occur than in the cervical and lumbar spine, because in the thoracic spine, we have our rib cage, which stabilizes the thoracic spine to a much greater degree, so disc herniations occur less frequently. When disc herniations happen in the thoracic spine, other than causing mid-back pain, a pinched nerve in the thoracic spine would cause or could cause pain or numbness or tingling that wraps around the back towards the chest. And then in the lumbar spine, when a disc herniation occurs, other than causing back pain, if it impinges on a nerve, typically that would cause pain radiating down the legs. And the pattern in which the pain radiates and in which muscles are affected can be very indicative of which nerve or nerves are affected. And so when you see a doctor about a disc herniation, they'll perform a very thorough physical exam to help them understand which nerve or nerves are affected based on where the pain travels and what muscles seem to be affected.
Understand. So I guess with regards to that, there is a difference between a disc herniation and a pinched nerve, right? We're not saying one necessarily causes the other, but it can. Is that correct?
Definitely. So a disc herniation, as Dr. Iyer showed us on the MRIs, is the physical structural change that happens in the disc, and that can be painful in and of itself, and that can cause neck, mid back, or low back pain depending on where it occurs. As Dr. Iyer mentioned, the disc contains fluid in the center, and it's then contained by a more tough exterior. So sometimes we use an analogy of a jelly donut. The jelly on the inside is the fluid inside the disc, and then the donut is what encases it. So a disc herniation, you can think of the jelly sneaking into the donut, or the jelly being squeezed so that it's deforming the donut. So that's a disc herniation, and that's what we see on an MRI. Now, depending on the direction that the disc herniates and the degree to which it herniates, it can cause a pinched nerve. If it herniates to the neural foramen, which is the space where the nerve exits out of the spine, then it can cause, a focal pinched nerve. For example, a disc herniation between the L4 and L5 bones may impinge on the L4 nerve if it herniates into the neural foramen, which again is kind of the exit ramp for the nerve to exit out of the spine. If the if the disc instead herniates straight backwards toward the central canal, it may impact a different nerve, perhaps a nerve that's traveling down to exit at the next level. Or if it's happening in the cervical spine where the spinal cord is, or in the thoracic spine where the spinal cord is, it can theoretically cause compression of the spinal cord, which may cause different kinds of symptoms like balance changes or loss of control of urine or stool. That's a much more serious condition anytime that there's pressure on a spinal cord. So the direction and the degree to which a disc herniates will determine if a nerve or multiple nerves or the spinal cord is impinged.
Okay. And Dr. Iyer, you mentioned earlier that some causes can be things like increased weight, genetics. Are there any other risk factors that you find can increase your chances of getting a herniated disc?
Yeah, and obviously, it is one of the most common questions we get asked when we see people with disc herniation. And truthfully, there's a lot of things. Like we talked about, the majority of these herniations occur mostly as a result of wear and tear. And it's wear and tear we pick up throughout our lives. And you use your back for everything. You use your back when you're sitting. You use your back when you're walking. You use your back when you're getting out of bed in the morning. So your back kind of feels the brunt of it. And over time, these things accumulate. Most disc herniations tend to occur in patients that are in their 40s and 50s, that damage kind of accumulates over time. A lot of the studies that have been done on the topic haven't found any sort of major predisposing factor. We touched on some of the things earlier that kind of increase the chances. So people have thought that people that have, physical jobs that involve a lot of lifting, that may be a predisposing factor. Jobs or people that don't have as much physical activity. So as the back muscles get weaker, maybe the disc carries more load, and that may increase the chances of having a disc herniation. We talked about weight, and we talked about genetics. Smoking is another big factor. So nicotine does injure the disc. So people that tend to smoke can have an increased risk of disc herniation.
And Dr. Barsoum, if I was home and I was doing something around my house and I felt something happen, my back started to bother me, how do I know that I have a lumbar disc herniation or cervical thoracic? And what are the main symptoms?
So that's a great question. A lot of times patients will come in and say, oh, I just bent over to pick up a sock and I felt it happen, or I was bending over to get the baby out of the crib and I felt it happen. So sometimes it feels like there's one specific inciting event that causes it. But as Dr. Iyer has mentioned, these are usually the event of chronic wear and tear. And sometimes it's something that kind of is the straw that breaks the camel's back, or it can happen gradually. The typical symptom is pain. If it happens in the cervical spine, it's going to cause pain in the neck. And the lumbar spine typically will cause pain in the low back. Now, in general, disc herniations hurt more when you're sitting and maybe a little bit less with standing and walking, although that's certainly not a hard and fast rule. There's always exceptions to that. But as a general rule, it does, especially in the lumbar spine, disc herniations tend to hurt more with sitting, especially when you're sitting leaning forward, like sitting down to tie your shoes or picking something up from the floor. And the reason for that is that the highest pressure that's measured inside the disc is when you're sitting leaning forward. And that's why another potential risk factor could be sitting with poor posture, because that increases the disc pressure. The main symptoms, like we said, are pain. And again, depending on if a nerve or nerves are involved, sometimes the pain can radiate down the arms or down the legs. The best way to know if you have a disc herniation, if you're having pain, is to see a doctor who will then perform, a physical exam to help understand if there's seemingly a problem at the disc and if it's affecting the nerves. The physical exam is probably the most important factor in determining if really there is a disc herniation, because as we get older, disc herniations and degeneration of the disc become very common. So if you just take a look at an MRI of a totally asymptomatic 60-year-old, for example, it's very likely that you're going to start to see evidence of disc degeneration and potential disc herniations as well. But if they're not having any symptoms, then we don't really worry about those discs per se. So that's why I think that the physical exam is the most important factor. And then we oftentimes will get imaging like an MRI to help us correlate with the findings that we see on the physical exam.
Okay. And during your physical exam, Dr. Barsoum, are there any things that you specifically look at while you're doing that?
Sure. So if we think about the cervical spine, the neck, we look at range of motion. Again, usually it will hurt more with cervical flexion, so bending your head down, and maybe less with extension, although there are certainly exceptions to that, like if the disc herniation is going into the neural foramen that we mentioned before, where the nerves exit. Sometimes that hurts in the opposite pattern, so it hurts more when you look up and less when you look down. But we look at cervical range of motion and look for differences with side-to-side rotation. And then a very important part of our physical exam is doing a neurologic exam, looking at strength, sensation, and reflexes in both arms. If we're talking about the cervical spine, looking for any differences side to side or any abnormal findings like unusual reflexes that we would not expect to find. That may be an indication of pressure on the spinal cord. Then when we're talking about the lumbar spine, again, we look at lumbar range of motion. Again, typically disc herniations hurt more with bending forward and less with bending backwards. And then similarly, we do a neurologic exam looking at strength, sensation, and reflexes in the legs. In the lumbar spine, we also do a very close physical exam of the hips, because oftentimes lumbar spine pain and hip pain can overlap, and one can look like the other. And sometimes we can head down a road of treating someone for low back pain and it doesn't get better as we expect it to. And then we realize that actually the problem is coming from the hips. So we look at hip range of motion and some provocative maneuvers, meaning we position the hips in different positions to see if that produces any pain. So that's one extra factor that we look at, especially in the lumbar spine.
Perfect. And obviously, with everything going on in our environment right now, typically COVID, telehealth seems to be quite a big topic of conversation recently. And do you think you'd be able to diagnose a disc herniation through telehealth?
I definitely think so. Like we talked about, a lot of the information that we get from the history, meaning how the patient describes the pain, and then the physical exam can really give us a good indication if there's a disc herniation happening. Certainly, it's a little bit more challenging doing a physical exam over telehealth, but what we do is we like to give the patients kind of instructions prior to a telehealth appointment saying, wear comfortable clothes that you're going to be able to move around in, try to be in an open space where you can walk and bend and have a chair so that you can do some of the tasks that we'll ask. And then we kind of walk the patient through a neurologic exam so that they're testing their own strength and sensation. We can't really test reflexes over telehealth. So that can really give us a good indication. Now, if there are any red flag symptoms such as significant weakness, loss of control of urine or stool, or sudden balance changes, then oftentimes we will want to see the patient in the office to evaluate, because that can be an indication of something more serious going on, such as pressure on the spinal cord.
Absolutely. Dr. Iyer, anything in regards to telehealth on your end?
Yeah, I mean, I agree with Dr. Barsoum. I think it's a very valuable tool, and I think you can get most of the way there when it comes to diagnosing a disc herniation. It's a little bit probably harder for herniations in the neck, in the cervical spine, because the location of pain with those types of herniations is a little bit more challenging to determine, especially over telehealth. Although, we have the MRIs, usually patients upload them to their portal. So we have a chance to look at the MRI. We have a chance to review it with the patient. You can talk in great detail with the patient, oftentimes from the comfort of their own home, where they can kind of describe exactly where they're feeling the pain. You can go over the images with them and really kind of get pretty close to an accurate diagnosis, I think, in most cases. Almost certainly most of the time in the low back, and in the neck, like I said, it's a little bit more challenging. But the nice thing is, if there's ever any question on my end or even on the patient's end, it's a nice way to get to know each other, to review everything, and then come in for any further evaluation if necessary.
Yeah, okay. And then for you, Dr. Iyer, I mean, I get this a lot when treating patients for back pain. A lot of times they'll ask me, can my disc heal? Will it ever get better? What's your take? Is there anything in the literature that gives us an idea? Can it heal on its own?
So the good news is yes, it definitely can heal on its own. So it's a two-part answer, right? So disc degeneration is kind of like getting gray hair. You're not going to escape it. It's going to happen at some point, and it pretty much moves in one direction. But that said, when you get symptoms of a disc herniation, whether it's back pain, leg pain, arm pain, any of that, 90% of those, the vast majority of those, are going to get better on their own. With time, a little bit of physical therapy, a little bit of oral anti-inflammatory medication, Tylenol, those types of things. Most of these things do get better. It's really when the symptoms, either one of two things. One, like Dr. Barsoum mentioned, you have some of these red flag signs like weakness, you have bowel and bladder issues, balance issues. Those are more serious and concerning things. That's when, you can't really wait to see if it gets better. Sometimes people are just so miserable. These are some of the most painful things that can happen to a person. So it's an incredibly painful condition. And sometimes the pain is just too much to bear to say, well, let me wait 4 to 6 weeks and see where this goes. But the vast majority of cases, absolutely, I would say, from the onset of symptoms before you really go down the road towards any intervention, whether it be injections or surgery, really waiting 6 to 12 weeks is usually a reasonable way to go. And your disc herniation can get better, at least your symptoms can get better in that time frame.
Awesome. It's very good to know. And Dr. Barsoum, you'd be the one handling a lot of the non-surgical care. Uh, Dr. Iyer did mention a couple things like medications, injections. Are there any specific things that you have used that you find to be very helpful?
Definitely. So there's kind of a big spectrum of tools that we have to manage disc herniation and the pain associated from a non-surgical perspective. What I usually tell my patients, when I see them for an initial visit for a disc herniation, oftentimes when they're coming in with an MRI in hand and they've seen that they have a disc herniation, they're worried that they may need surgery. And my answer is sometimes disc herniations require surgery, but oftentimes, as Dr. Iyer mentioned, we can manage the symptoms and resolve them without needing surgery. In general, I tell patients that I refer patients to surgery for one of three things when they have a disc herniation. One is if they have a progressive neurologic deficit, so weakness in the arm or leg that is getting worse. That is not something that we want to wait on because it may become worse or permanent. Second is if they're having any loss of control of bowel or bladder function. And third is if they have chronic pain that doesn't get better with conservative measures. So along the spectrum of what we can do with conservative measures to manage disc herniations, physical therapy is really very, very most of the time for disc herniations. And oftentimes we have to make the distinction to patients. Sometimes they come in and say, well, I did physical therapy and it wasn't very good or it didn't help. Good physical therapy is helpful, but not all physical therapy out there in the world is good. In general, exercise-based physical therapy is going to be the most helpful. And within that, for a lumbar disc herniation, for example, we work on three basic categories or tenets, three goals in physical therapy. One is building up core strength, and core is not just your abs and your back, but a lot of times it's strength coming from the glutes. Second is working on lower limb flexibility, because if you have very tight hamstrings, for example, that's going to cause a tilt on the pelvis, which is going to cause more strain in the low back. And then third, working on lumbopelvic rhythm, so how your back, hips, and legs sort of move in unison so there's not undue stress at any one spot in the kinetic chain. So exercise-based physical therapy is almost always a very important part of conservative care with a disc herniation. Sometimes we use medications to help manage the pain, and medications also are varied. Oftentimes Tylenol is a good starting place. Anti-inflammatory medications can be helpful as long as the patient doesn't have any contraindication or reason why they can't take an anti-inflammatory medication. A reason would be, if they're on a blood thinner for another problem, then they may not be able to take anti-inflammatory medications, or if they have some upset stomach when they take it. And then there are also medications that are helpful for nerve pain, and those can be helpful if we have a pinched nerve along with a disc herniation. Sometimes we have to escalate care and go to an intervention like an epidural injection. An epidural injection is placing a steroid, an anti-inflammatory, around the irritated nerve or nerves or disc, which can also be helpful. Epidural injections in general are more helpful when a disc herniation is causing a pinched nerve that's causing, pain down the leg or pain down the arm. And typically epidurals are not as helpful if the disc is only causing back pain or only causing neck pain. So it's more helpful for the referred symptoms that come from a disc herniation pressing on a nerve. And then, anywhere along that spectrum of conservative care, if we've kind of exhausted our options and the pain is not getting better, or if the pain is really severe, then we consider a surgical consultation along those lines as after we've tried some of the conservative care.
Perfect. I couldn't agree with you more with some of the physical therapy stuff for sure. A lot of the exercise-based treatments do work. It takes some time, but generally people, like you said, they do get better. Now, as we go down that road of conservative management, as you said, if something's not getting better or it's progressive neurological weakness, then we would send them along to Dr. Iyer. So what are some of the surgical options that people may expect or that you perform?
Yeah, so like with any spine treatment, it really is hard to sort of give a blanket answer, right? Everyone's spine is like a fingerprint. It's different. People's spine degenerate in different ways. They have different alignment, for example. Some folks have a little scoliosis, others don't. So it's always hard to say for sure that this is the surgery for even a bulging disc. But for the most part, the majority of disc herniations in the low back will benefit from one of two procedures, usually a laminectomy or a microdiscectomy, or a combination of the two procedures, a laminectomy and a microdiscectomy. Basically, the goal of all of these procedures is to remove the pressure on the nerve. So if we go back to our PowerPoint here, so we looked at this, for example, let's go to this one. So we saw here, this is a normal disc, how the disc is kind of sitting in the front over here. The nerves, which are these little dots in the back, are sitting nice and free. Versus at L5S1, you have this bulging disc touching up against these dots, which are the nerves running down to the legs, right? So the goal of surgery typically is an incision in the back, and the size of the incision can vary, but usually the incision comes in the back. We come in from your back over here. This little arch of bone in the back of your spine is actually called your lamina. So we have to usually remove just a little bit of bone, usually no more than a few millimeters, so we can see the nerves in front of the bone. We pull the nerves off to the side and then remove just this bulging portion of the disc. Dr. Barsoum earlier kind of mentioned how the disc is like a jelly donut. You can almost see it here, like this is the jelly, and these black bands are like the outer sort of crust of the donut. So we leave everything inside, just take that little piece of jelly that's squirted out. That surgery can be done, as I said, in a number of different ways. You can make an incision usually a couple of inches. You can make an incision as small as, a millimeter or two. And now with minimally invasive techniques, or not a millimeter, sorry, a centimeter or two, I should say. And now with minimally invasive techniques, we can do that. The recovery is usually pretty quick. You're able to get out of the hospital the same day in most cases. And the pain usually gets better pretty much right away. So that's really, it's a rewarding operation.
Okay, and in regards to the surgery, how long would recovery typically take? Let's say I'm a runner or a cyclist and I want to get back to some of that activity.
Yeah, so recovery typically takes about 6 weeks to 3 months is usually what I say. So for most patients, the first few weeks after surgery, we pretty much don't want you to do anything too crazy. The biggest activity that I prefer or I encourage people to do is walk. So walk as much as they can. Avoid bending, lifting, twisting type of activities. All the stuff that Dr. Barsoum had mentioned earlier as sort of risk factors or things that load the disc more, so sitting in a slouched position, sitting kind of all day, for example, those are all things that can increase the risk of something called recurrent herniation or a reherniation of the disc. And that happens again because just like a jelly donut, right? When you take a bite out of the jelly donut, sometimes the jelly squirts out and falls, for me, it falls right on my pants, like immediately always. But so that the jelly squirts out, that hole in the donut is still there. So we don't really at this point have any tools in surgery to repair that hole reliably. So we kind of count on your body to scar it in. And that really happens over the first 4 to 6 weeks. So the risk of recurrence is highest during that time. And the further out you get, the lower the risk of recurrence. So at 6 weeks, typically I feel comfortable getting people started back to whatever their day-to-day activities are. And for example, if you were a runner, I'd say, start very slow. Running is an activity that loads the disc, right? So I'd say start at about 10% of your normal intensity. So if you're out there running 6 miles at like a 7-minute pace, I'd say do like an easy 1 mile at 10 minutes or something, see how you feel the next day and slowly build up to it. And my goal for you would be by 3 months post-op, you're able to get back to your regular activity levels.
Awesome. And if we're looking conservatively, Dr. Barsoum, I guess on average, how long do you typically see people recover non-surgically?
Kind of a similar time course. A lot of times when, if pain has been going on for a long time, it takes longer to work through it compared to a more acute problem. So if somebody comes in with, really acute pain, just started a few days ago, just started a few weeks ago, or maybe a couple of weeks, then we say by 6 weeks, we expect them to be a lot better, if not all the way better. Sometimes when patients come in and they've had, a disc herniation that's been there for 10 years or 20 years and this kind of chronic pain picture, doesn't mean that we can't make the pain better, but sometimes it takes longer to work through it. So I'll tell those patients, if you've come in with pain that's been going on for 10 or 20 years, then when we see each other back in 6 weeks, I'm hoping that you tell me you're 25% better or 30% better or maybe up to 50% better. That's going to be a big step in the right direction. And then we modify our plans to get more improvement from there. But in general, I would say a similar time course of 6 to 12 weeks, sometimes shorter, sometimes it can be longer too.
Perfect. So before I get or possibly get a herniation, what can I do to prevent that altogether?
Great question. So maintaining a healthy weight is important. So doesn't mean that you have to be, perfectly slim, but maintaining a healthy weight and sometimes even losing a few pounds can make a big difference for the lumbar spine. Avoiding activities that we know really put too much strain on the disc, like sitting for hours on end or sitting with a poor posture especially. So I tell my patients, nobody should be sitting for more than an hour without taking a minute break to just stand up and stretch, walk around, do a few steps. Certainly it's a little bit harder with this COVID world that we're living in. We're probably doing a lot more sitting than we should be, but I really encourage my patients to take a break after every hour, certainly after every 2 hours of sitting, to stand and stretch just to give your back a break. Being mindful of your ergonomic setup, so how your computer and mouse, your phone, your monitor, everything is set up when you're working, again, especially because a lot of us now are working from home. So if you're sitting in a position where, if your computer monitor, for say, is too low and you're looking down for a long time, that's going to cause more strain at the cervical spine and the lumbar spine. If your chair is either too high or too low so that you're not sitting in a good position, that's going to cause more strain at the cervical and lumbar spine. So being mindful of, avoiding positions or activities that put undue stress on the discs, maintaining a healthy weight, and then maintaining activity. So a sedentary lifestyle is not good for the discs. The discs do well with this loading and offloading. So being active is very important, especially as you get older.
Awesome. That's all the questions I have for you guys today, but I do see some questions coming in from the viewers. And some of these are really pretty good. A lot of questions that I tend to hear a lot. So one question is, is there a difference between when someone says I have a disc herniation or a bulge? Is it semantics, or is there anything to that?
So most of it is it ends up being semantics. So the most important thing ultimately is the patient's symptoms, right? So it's sort of correlating where they're having pain with which nerve is compressed on the MRI. So even if we go back to our slides and look at these different disc herniations, right? So we have this one. So some people might say, oh, it's just a bulge, it's not a herniation. I'll show you one where this is a large, piece of disc that's sitting in the canal. So that's a herniation. But some people might say, well, you know what? No, this is a herniation too. So the idea of a bulge or a herniation is really referring to shades of the same thing. You can have a relatively small disc bulge and have really bad pain. You can have weakness. You can have all of those symptoms that we've talked about earlier. Or you can have a huge disc herniation and have almost no symptoms. So the key always comes down to what the patient's symptoms are, not necessarily what we see on the MRI, because, again, I think we touched on this earlier, like the degenerative changes accumulate over time, and that's normal. It doesn't necessarily mean we need to do anything about it if you're not having symptoms.
I'll just add another thought there. So I think disc herniation is kind of like the umbrella term, and then there's a lot of different terms that we use that fall into that category, like a bulge, maybe a herniation, a protrusion versus an extrusion based on the shape of how the disc is pushed out. And one thing, sometimes when you look at an MRI image and you see this really ugly looking disc and a big piece of disc has herniated out, sometimes even the disc herniation, the jelly separates from the donut. Sometimes those actually do the best. Sometimes those recover, the body can resorb that disc that's herniated out. So sometimes, the ones that look the worst don't always have the worst outcome.
And another one I tend to get a lot of that two people mentioned here is, someone gets the results of their MRI and it says stenosis. So can we quickly maybe go over what exactly does stenosis mean, and is that related or relevant in a disc herniation?
Sure.
Sure. So stenosis in general means that there's less space than there's supposed to be. So you can have a coronary stenosis in your heart if there's less space for the blood to travel through a blood vessel. So the term stenosis is not very specific, just means less space for in our case here, less space for the nerves to travel. Now, there's kind of two main categories of stenosis in the spine. There's central canal stenosis, where the disc or anything else is impeding on the space where the nerves or the spinal cord are traveling down. So that would be with this disc herniation here, the disc has pushed sort of straight back. It's a little bit deviated towards the right side, but basically straight back, and that's causing central canal stenosis. Versus if the disc pushes out to one side or the other, it can cause foraminal stenosis. Again, the foramen is where the nerve exits from each side. So you can have central canal stenosis if the disc is going straight back, or you can have foraminal stenosis on the left or on the right if the disc is going in that direction.
Yeah. So yeah, I don't have much to add to that. I think the only thing I'd say is that when we say stenosis or you see stenosis on an MRI report, it is a narrowing, as Dr. Barsoum said. So just like you think about coronary artery stenosis, narrowing of the artery, right? Lumbar stenosis is narrowing of the space for the nerves, which is right here in the lumbar spine. So it's basically a narrowing of this space. Narrowing of that space has slightly different symptoms than a true disc herniation, but you can have both at the same time. You can have one but not the other. And again, that kind of goes back to even when we talked about the surgical plan, people's spines are different. And so if you just look at your report, you're going to see a lot of these terms. And the key is speaking to your doctor and figuring out what change is actually driving your symptoms, because the key to having a successful outcome after treatment, whether it's therapy, whether it's injection, whether it's surgery, is really knowing what the real driver of your symptoms is. It's the diagnosis, not so much the changes that are seen on the MRI.
Yeah, I would just to echo that. I think that's kind of one of the most important things to take out of this is that there are so many different reasons why a person can have low back pain. And if we just take a look at, what we see on an MRI, sometimes we might be treating the wrong source of pain. We may be treating something that looks bad on an MRI, but it's not actually the source of pain. So that's so important that we really do a good history and physical exam, then correlate those findings with the MRI to understand where the pain is coming from so that we can direct both our conservative care and our surgical, if needed, care to the actual source of pain to get a better outcome.
And if someone has a disc herniation, they've recovered, and maybe they have a flare-up, because that tends to happen from time to time, what do you guys suggest maybe the best course of action during that flare-up? Is it a medication? Is it a position, an exercise? What do you think about that?
So generally, I think, in my case, it's usually patients after surgery, right, that have a recurrent disc herniation. But even in most cases, I think when you have a flare-up, it sort of depends on how long it's been since your last flare. So if you did great for a year or two and then the pain kind of started, I think we basically go back to square one, where you start with physical therapy and medications and sort of work your way up the pathway to and hopefully, and usually, again, it kind of acts like a first time kind of thing where it gets better. If you had some pain and then got a little bit better, but not really, it kind of always bothered you, and then it gets worse, that's a little bit different. And then you kind of have to sort of treat it a little bit differently, whether it means going to an injection sooner or thinking about surgery, or at least seeing a surgeon sooner to decide if that's warranted or not.
Got it. Okay. And I know you mentioned, Dr. Iyer, before that typically in terms of return to your activity levels, let's say if you're a runner, you mentioned, it could be a couple months. Is swimming a similar time frame there, or is that a little bit different?
So swimming generally, especially like freestyle is usually okay as early as 4 to 6 weeks after surgery. The nice thing with swimming is your discs are offloaded, right? The pool and the water help support some of your body weight. That's why it's really nice for a lot of musculoskeletal problems, whether it's arthritis in your knees or hips, or problems with your back, to be in the pool and have that little extra support. So generally speaking, swimming, the timeline to recovery is a little bit sooner, but like anything else, if you're an ultra competitive swimmer, I would say, you got to give yourself 3 months before you're sort of feeling good enough to get back to, your pre-injury level of competition.
Understand. And kind of switching gears to the cervical spine a bit, if somebody is currently experiencing pain in their hands, maybe not weakness, but still feels that pain, doesn't really want to have any injections, doesn't want to have any surgery, are there certain things that conservatively, Dr. Barsoum, that we can also provide?
Definitely. So, certainly I would want the patient to have, an evaluation with the physician to make sure that there's no concerning signs, but, assuming that their pain is coming from a disc herniation, causing impingement on a nerve, causing that symptom in the hand. Physical therapy is actually very, very helpful for, a pinched nerve in the neck. We talked about in the back where we want to work on core strength and flexibility. In the neck, a lot of times we're thinking about posture, because we all fall into a bad posture from being on the computer for a long time or driving or, so many different reasons. So working on posture so that there's not undue stress on those discs can be very helpful. Another thing that's more helpful in the neck than in the lumbar spine is something called traction, where a force is applied to kind of pull up and stretch and alleviate some pressure on the disc. That can be performed by a physical therapist, or you can buy, on Amazon, my go-to, an inflatable cervical traction, where you can do that at home. I wouldn't recommend you do that before you try it out with your physical therapist to see if it's the right thing for you, but physical therapy absolutely can be very helpful for disc herniations in the neck causing pain or numbness or tingling in the hands.
Okay, and is that similar to like a typical collar that one would wear, a cervical collar, or is it a little different?
Different than a collar. Collars are sort of controversial. Collars are helpful like after you've had surgery and you have to limit range of motion, or if you've had like an acute injury to the spinal cord. In general, we don't want patients to be dependent on a cervical collar or on a back brace, because we want to train those muscles that we're talking about strengthening to form like a muscular brace. So sometimes they can be helpful in a short term for managing pain, but not something that we want the patient to have to depend on for daily use, especially when it comes to like a lumbar brace. A lot of times people will put on these tight corset braces, which can be helpful for short-term pain relief or if you're doing strenuous activity, but we don't want you to depend on that because we want those muscles to do the job.
Okay. And I think 2 more questions we could get to. One I think I already know your answer, but is walking helpful both conservatively and, as you mentioned, Dr. Iyer, post-surgically, and how long would you suggest somebody to walk for, maybe start walking at?
So yes, I think walking is very helpful. And I think the short answer is you can walk pretty much as far and as long as you feel comfortable doing. Listen to your body. There's no gold medal for walking 3 hours the day after surgery, right? So I think there's a little bit of, you have to be smart about it. But in general, yeah, walking is a great exercise. It doesn't load the discs a lot. It keeps things moving. It keeps your nerves gliding, which helps after surgery, and it engages your core muscles. So it's a really good activity that and after surgery, most people are able to do it. They walk out of the hospital, so it's something that most people are able to do relatively quickly after surgery.
Anything on your end, Dr. Barsoum?
I would agree. A lot of times patients come in and they, one of their biggest complaints is I can't walk as much as I was able to before. And I'll tell them that the best exercise to improve walking is walking. So kind of using your body as a guide, not necessarily walking to push through pain, but walk as far as you feel comfortable. And then, maybe the next day you can go a little bit further. Maybe a week later you can go a little bit further. But I think it's an excellent exercise in general.
Got it. And last question, this one's for Dr. Barsoum. Do you find that acupuncture can be helpful for this issue?
I think some people respond really well to acupuncture. What I'll say is that it doesn't replace exercise-based physical therapy, but as an adjunct, it can be helpful. Some people respond really well to acupuncture, some people don't, but I think it can be helpful. So oftentimes patients who have tried it before and had a good response, I'll encourage them to try it again. Someone who hasn't tried it before, usually I'll tell them, give it a try, go for a couple of sessions. If you find it helpful, keep going. If after a couple of sessions you don't find it really helpful, then you may be a person who just doesn't respond as much to it.
Got it. Okay. Well, that's all we have for today. I want to thank you both for your time and expertise. I think it was quite a helpful webinar and event for some people to get an understanding of, what is a disc herniation? What can I do about it?